Welcome to Worker Wellbeing and High Performance Workplaces, two sides of the same coin. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We'll collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all these items when they're available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Kimberly Jeanette. Dr. Jeanette is president of the Center for Workforce Health and Performance and affiliate faculty at the University of California, San Francisco Institute for Health and Aging. Dr. Jeanette has studied and practiced in the health and well-being field for more than 3 decades, including at RAND, the Department of Veterans Affairs, and the Integrated Benefits Institute. Dr. Jeanette received a doctorate in public health and sociology from the University of Michigan, Ann Arbor, and her Master's of Science in Public Health from UCLA. And now I'll hand it over to Kimberly.
Thank you, Angie. I'm delighted to be here, and thank you to WWDPI for hosting this webinar. I'm going to present a lot of material today, some at a high level, but a lot at a detailed level, really trying to bridge various perspectives out there in the community to clinical research perspectives. So to get that going, let me just give a little brief information on who we are at the Center for Workforce Health and Performance. We're a non-for-profit organization. We are located in San Francisco, California, in the East Bay, but we serve nationally and internationally. And we're dedicated to understanding how we can better spread research and educational opportunities involving practitioners and researchers together in improving health and performance. And our aim is to pull together and translate research for a variety of practical and applied audiences, in addition to conducting primary research around the work-health relationship. We also point toward others' research and applied work to help spread what is known about worker well-being and performance, and what gaps are yet to be filled, as well as promising future research and development efforts with practical implications. Today I'll be presenting on the importance of worker well-being for healthier, happier, and longer working lives. I'll describe a set of work-related outcomes that tie worker well-being to workplace performance. Some of the research I'll present was conducted while I was at the Integrated Benefits Institute, IBI, and you'll see mention of several other sources of evidence as well. Worker well-being should be of interest to a variety of stakeholders and key decision makers, including workers, employers, and policymakers. While their perspectives may vary, they all could benefit from sound evidence around the relationships between work and health. Today I'm going to cover a variety of topics, but I've broken them into 4 main sections. First, I'll start by reviewing definitions of worker well-being, since there are a variety of ways to define and measure the concept. Second, I'll connect the concept of worker well-being to what it means to be a high-performance workplace and how that concept can be measured. Third, I'll reflect on the importance of a systems perspective for understanding how the parts are related to each other and the key value of acknowledging the multidirectional relationships. Health affects work just as work affects health, and these relationships exist in a context that must be measured, not ignored, if we are to make progress on improving worker well-being. Finally, I'll discuss implications for both research and practice. So let me begin by what we mean when we say worker well-being. There are many definitions of well-being, and for this presentation we start with the broadest definition. I'll use the World Health Organization's definition of health as contained in its constitution, which they define health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Around the various ways to measure well-being. But let's start with what we know about work-health relationships. In February of 2017, IBI and some of its members sponsored a special issue of Health Affairs on the work-health relationship with policy briefings in Washington, D.C. and San Francisco. And I highly recommend this special issue as an excellent reference on the evidence base, as it covers about a dozen papers and a range of topics on how work and health are interconnected. We are continuing to follow up with the authors of these papers to highlight their work in ways that resonate with a variety of audiences, not just researchers. This translational work includes a series of briefs. The first one spotlights organizational culture and climate. On the topic of organizational climate and culture, we also sponsored a Twitter chat on Dr. David Rebkov's work. He's a Stanford physician researcher, and his paper in this special issue highlighted the connections between the work environment and hypertension. The 5 areas that we summarized the dozen papers into include prevention and wellness, supportive health intervention, supportive work intervention, organizational culture and climate, and public policy. We believe each of these areas have unique usefulness for various audience types. I highly recommend obtaining this journal, and I have my contact information at the end if you would like more information on it. Let me transition to one of our studies, which was in that special issue. Our paper focused on the importance of physical and cognitive job demands on productivity as measured by the outcomes absence and presenteeism. And presenteeism occurs when an individual attends work while ill or injured and isn't able to perform at their usual way of performing. In this paper, we examined the influence of workplace safety and employee health in relation to job demands across approximately 17,000 employees working for 314 large, mid-sized, and mostly small businesses in Colorado. These data come from the Pinnacle Assurance study launched by workers' compensation carrier Pinnacle Assurance in Colorado. They were interested in how they might influence injury events by better understanding the connection between workers' comp claims and non-occupational injuries and illnesses. As part of these efforts, a health risk appraisal, including health and work outcomes information, was administered to the employees who participated in the worksite wellness program offered by the workers' comp carrier. We found that both workplace safety and employees' chronic health conditions contributed to absenteeism and performance, but their impact was influenced by the physical and the cognitive difficulty of the job. If employers want to reduce health-related productivity loss, they should take an integrated approach to mitigate job-related injuries, promote employee health, and improve the fit between a worker's duties and abilities. Further analyses with these data around work stress and variation in outcomes across settings suggest the importance of workplace factors and the potential for context redesign to influence work-related outcomes. So let me get a little bit more specific about how we connect the various parts of what can often be complex organizational work and connect employee health to operational and business outcomes that matter to employees and employers. How might we connect these employee workplace outcomes, such as absence and presenteeism, to both workplace culture, the culture of health, and operational and business outcomes? In a recent IBI publication, we outline those connections in employee well-being for better business results. the publication is focused on an integrated approach in connecting well-being to business performance. In this report, we draw upon a current review of well-being measurement instruments and reflect on the various ways in which well-being is conceptualized and metrics developed around it. Well-being can be measured subjectively or objectively, and different academic disciplines, economists, sociologists, and psychologists often spar with each other on whether feeling happy with your living environment, for example, is better, the same as, or worse than living in a neighborhood with a lot of broken windows. Of course, the correlation between a subjective measure, like feeling happy, and an objective measure, like the number of broken windows in a neighborhood, is high, and there are other such examples of questions and observational items that show correspondence with each other and with the outcomes of individual and societal importance, such as worker health and productivity. In addition to how an item might be measured, there are various dimensions of well-being that can be rolled up into a global well-being measure. In this report, we outline examples of how 5 dimensions of well-being, financial, mental, physical, social, and spiritual, might be reflected in subjective and objective questions. We are not presenting this as a well-being measure, only illustrative of the ways in which well-being can be measured across various dimensions, financial, mental, physical, social, spiritual, there are others as well, and across different modalities, subjective questions around feelings and perceptions and opinions, and objective measures that are more observational in nature, often around the context. Now, while global measures of well-being are important for comparing groups, cities, and countries in aggregate because they use uniform measurement, the item-level detail is required over time by researchers to understand what factors account for the greatest differences in outcomes between groups over time. In this way, new policies, practices, and work designs can be developed and measures refined to support well-being improvement across groups in ways that are equitable and impactful. So let me talk a little bit about how we measure high-performance workplaces. That will help us better connect well-being measurement to measures that matter to employers. But to do so, we'll have to deeply understand what matters to both employees and employers when it comes to performance. What is required for employees to do their best work, and how do employers measure high performance and productivity? So let's take a deep dive on what leads to high performance. This is a deep dive on the diagram I showed earlier from the Wellbeing for Better Business Results publication. Here we outline the dimensions of workplace culture that directly impact employee outcomes, followed by how those employee outcomes affect operational and business outcomes of interest to employers. Oftentimes, particularly as organizations get larger, those tasked with improving and managing employee health work in isolation from one another, in siloed departments that might not communicate well with each other, share resources, or know about potential duplication of efforts or important gaps needing attention. Here we identify 3 such functional areas in an organization that might be siloed, but there can be more, and they can go by different names in any individual organization. And certainly, as organizations get larger, they have a tendency to have more siloed departmental arrangements. But typically there are at least 3 departments engaged in the following types of activities as represented under the workplace culture of health dimension here. There's often a department that's responsible for promoting health and wellness, and another for preventing harm, typically involving safety efforts, and often sometimes a third for managing illness or dealing with health-related benefits. Health promotion and wellness activities typically involve issuing a health risk appraisal, doing biometric screening, perhaps even having an on-site clinic, and might include the involvement of a chief medical officer, typically based on the company's size and industry. Preventing harm often involves safety and workers' comp professionals, efforts to reduce hazards in the workplace, typically physical hazards that can cause or exacerbate injury or illness. Now, while most attention has been paid to physical harms, There's increasing attention to psychosocial harms in the workplace. Finally, activities directed at managing illness include disease management efforts, development of high-quality provider networks, and access to effective treatments. These efforts are aimed at worker health, and current evidence closely ties employee health to the employee workplace outcomes of presenteeism or performance, absence and attendance, disability leaves, return to work, and permanent work departure. Operational managers know the effect on key business metrics when workers are absent or performing poorly. Let's take a deeper look at the interrelated influences. And we'll get into a little more detail in terms of the right column you're seeing here under operational and business outcomes. So bear in mind, you'll see a little different orientation of the diagram now, but we're blowing out that blue column, which gets at satisfying customer demands, delivering product and service on time, and we're going to connect those kinds of operational impacts and business costs to work climate, employee factors, and management factors. So this is a busy diagram. It represents what is often called a measurement diagram that researchers use to try to connect concepts to the underlying measures that are going to be used. And for this particular study, it's an open recruitment study that CWHP is currently conducting, and we're exploring the interrelationships between these different dimensions. For each employer we currently have involved in the study, we work closely with their human resource departments or whatever relevant unit is understanding of the various structures and functions in their organizations and what employees do. We often identify the main departmental units by function and randomly select a diverse sample of functional units. For those units, we further sample managers and their direct reports, and we field a secure online survey to both the managers and the employees. This is an IRB-approved study. Information around the sites involved and managers and employees participating is confidential and only known to the research team. Thus far, we have 2 sites completed, a health system and a county. We have produced 2 IBI reports using these data and continue to recruit employers interested in participating. The employee survey obtains information on the employee's health status, including chronic conditions and symptoms. We have often found that an individual might have a diagnosis of a condition, but if their symptoms are under control, the ill effects of that condition on work outcomes is non-significant. Socio-demographic variables associated with health and work, such as age, education, marital status, and others, are also collected. The employee is asked to report on their attendance, job performance, and absence over a short recall period. Employees are also asked about their assessment of work climate using the General Social Survey Quality of Work-Life questions. These items collapse into 4 areas: safety, respect and trust, variety and learning, and workload. Research demonstrates that strong safety environments with high respect and trust, opportunities for variety and learning, and reasonable workloads are associated with better worker attendance, higher job performance, and less turnover. Managers are asked to reflect on the employee's attendance and performance record and how it affects operations and business costs. We also ask how the manager responds to these work disruptions. For one of the 2 IBI reports we have completed to date with these data, we find that work climate exacerbates the effect of health symptoms on absence and performance. Based on employees' responses to the work climate questions around safety, trust, learning, and workload, we classified the work environment of a department as having a supportive or unsupportive work climate. We assessed the extent to which individuals experiencing different levels of physical and mental health symptoms fare better or worse in terms of job performance outcomes in these different work climates. As expected, when symptoms get worse, absence increases and performance declines, but these effects are exacerbated when individuals are in unsupportive work climates. That's why we see the separation of the lines, or the different slopes for those lines in these graphs. The relationship between symptoms and work outcomes is more pronounced in unsupportive work climates than supportive ones. Using methods that allow us to see these differential effects will help us address equity issues around differences in health and well-being by group in addition to overall levels of well-being. Practically, these findings imply that returning an individual to an unsupportive work climate undercuts investments made in employee health improvement and treatment access. Context design efforts must be considered as the work environment has real and measurable effects on employees' health and work outcomes. What this shows us is context has meaningful influences on both health and the work outcomes that matter to employees and to businesses. And so we must take a systems perspective and move away from relying too heavily on measures that are easily available, because this perpetuates the over-reliance on outcomes that are easily observed, such as claims data. And it excludes the outcomes that we ought to be measuring more, such as these functional work outcomes that represent quality of work life, like being able to attend and perform on the job and having fulfillment from your job. What this means practically is that we must move beyond measuring only claims or utilization data, because these data represent current benefited users of the system. We must explore whole populations of workers and do so over time, and this becomes even more important as the world moves toward more of a gig economy with part-time work and more precarious work. Unfortunately, those charged with making employee health investment decisions for a workplace are most often asked to reduce healthcare costs. This is particularly true in the U.S. context. The easiest way to do so is not to measure anything beyond costs to the employer. And by shifting the costs of medical and pharmacy care to the worker and not measuring anything beyond these costs to the employer, an employer can show a rapid cost reduction, and that can be demonstrated in the near term. But if health outcomes are measured that are broader, including these kind of functional health outcomes for employees, and they're measured across the population of workers at all benefits levels, whether benefited or not, such a strategy would reveal treatment access problems among the workers and a logically related health decline over time. And there is research to show this, and research and evidence strongly connects health to these work-related outcomes, such as absence, job performance, and work disability. And employers ought to pay more attention to worker health, not simply health claims cost. Connecting the disparate departmental silos and bringing together the health promotion, safety, and disease management functions, either in conversation or structurally, can be fruitful ways for an organization to develop a more systemic population-based perspective to employee health and well-being for better business results. And certainly we argue including the broader measurement and the broader outcomes beyond medical and pharmacy spend can be a companion and a support to the dialogue and the cross-silo dialogue and work. I want to talk a little bit now as we move more into a bi-directional way of thinking about the way health can influence work. Work can also influence health, as we've seen, the work context, the nature of the job, and what I've presented. And certainly we're very much aware of the importance of health to being able to be productive and perform well on the job. About a little over 10 years ago, in 2006, the UK Department for Work and Pensions commissioned an independent review of the scientific evidence on whether work is good for health and well-being. And it has been well known and documented that long-term worklessness is harmful to physical and mental health. This review sought to better understand when, how, and under what circumstances work might be beneficial to health. We're often, particularly in the occupational safety and health community, looking at how work can be harmful, but work can also be beneficial. So we need to understand all sides and think of it as a system. And this review is very helpful in doing that and in making the case for paying more attention to both the harms as well as the supports and opportunities that employers have at their disposal to improve the conditions for healthy work and productivity. This review focused on adults of working age and the 3 health conditions that account for 2/3 of work disruption, at least in the UK, and I'd say this is fairly common. And the work disruption here is defined as sickness, absence, work disability, meaning time away from work, or long-term departure from the workforce. The conditions that accounted for 2/3 of work disruption were mild or moderate mental health issues, musculoskeletal and cardiorespiratory conditions. And these reviewers found that there was a lot of evidence of both the effects of health on work and work on health. On the whole, they found work is generally good for employee health and well-being, but the nature and the quality of work and the context of work can negatively affect overall health and well-being. And importantly, the work must be good work. So whether an employee is healthy, whether they're contemplating employer accommodations so they may stay at work or return to work after a work disability, attention to the context design and the nature of the work itself plays a big role in whether that employee's health and well-being will improve or decline over time. So many of you doubtless know about the iceberg model. It's used a lot to focus attention on the deeper work that often is needed to look at underlying factors. And social determinants of health are certainly part of that in understanding how beyond the healthcare system, there are other factors that affect the health of individuals, the functioning of individuals. When we observe individual behaviors and we look at those as events, what is happening? People are not exercising, people are not eating well. We get an overemphasis oftentimes on diet and exercise solutions. And that's akin to just seeing the tip of the iceberg because those behaviors are observable events. But to change those behaviors, we need to look below the surface, not just at the individual, but at social structures that support patterns of behavior. And these types of efforts are often called system redesign or context design efforts. And there are many companies and people within organizations responsible for this type of work. And many of you on the call may be responsible. Ergonomics certainly is part of this, but we're talking about organization-wide solutions and department-wide solutions as well that can be helpful. We are currently involved with a company, and so I don't mean to privilege them. That's where the quote comes from. Habits at Work in Chicago is one such context design company, and there are many out there. We only note this one because we're involved in a qualitative study with this company. We're following 3 employers that participated in one of their workshops titled Context Design for Wellbeing. So this workshop was specifically focused on improving employee well-being through context design. And what we're doing is following the 3 employers who participated in that workshop, and we observed the workshop. And we're following them to understand the challenges and opportunities that they face when trying to take what they learned at the workshop and implement these lessons in their respective companies. Context design demands a systems perspective, the perspective we've been talking about today. And oftentimes, these types of training start with the easily visible behavior that is the target of change efforts, the tip of the iceberg. How do you get employees to diet and exercise more, for example, to have a healthy diet and choose to exercise? Now, given enough time, and this was a 2-day workshop, the participants begin to get below the tip of the iceberg and discuss behavioral patterns across their organization that may account for the behaviors they're seeing. So they compare notes with each other and across the other teams from other companies, and they present their ideas. And this was a team-based training, so they had to bring at least 2 or more individuals who worked on health and well-being, but preferably also across departments. So they would maybe have an operations manager involved as well. And they challenge each other and dig deeper on how to change the behaviors that they are observing. They begin to share thoughts around why these behaviors exist and what might explain these patterns that could be influenced by the employer. They begin to understand that an overweight problem, for example, in the office, might be influenced by the sedentary nature of the work and the example set by senior leaders to eat lunch at their desk and be heads down and work all day. They begin to see that the deepest part of the iceberg reveals these assumptions and beliefs around what it means to be a hard worker and move up in the organization, and that if those ideals aren't changed, very little of the attention paid to changing the surface behaviors will result in any lasting improvement. So this work can be challenging, and tackling these assumptions and beliefs, both at the research level and the practice level and in conversation with each other, can feel beyond the scope of both researchers and practitioners. But we must challenge ourselves to dig deeper, else the improvements we seek to achieve will never be realized. But by working together, research can inform practice, and practice can inform research. Of course, a fallback option is to allow the system to play out as currently set up. So we wait until someone develops a chronic disease or until an injury occurs, and we try to apply the best strategies available to allow that person to either stay at work or return to work in a healthy and productive fashion. This is pretty much the way we operate now. It means we spend a good deal of time on disease management efforts and less on prevention. The exception might be in the safety area, where policies and practices demand compliance with incident prevention efforts. There remain physically hazardous jobs and workplaces, and such efforts must continue and be ramped up in some cases. But on the whole, there have been great improvements achieved on reducing workplace accidents and injuries. Psychosocially hazardous workplaces are receiving more attention as researchers investigate the effects of work stress on safety incidents and the development or exacerbation of chronic conditions. Drawing upon strategies used to curb physically hazardous work environments, we can apply lessons to address reduction in psychosocial hazards that may exist in the workplace. We need to focus our attention on prevention and treatment, not one at the exclusion of the other. And as this presentation is sought to demonstrate, we need to understand how the various disparate perspectives we have as employers, employees, clinicians, policymakers, and researchers can be brought into connection with each other and reflect on the overall context in which we work and live. I want to talk a little bit about what we're doing now to try to bridge the research and practice divide. We have an ongoing contract that's just ending with the Patient-Centered Outcomes Research Institute. We're at the end of our 2-year project. Final phase is disseminating the results of this work. And we relied for these efforts on qualitative interviews, expert panels, and lit reviews to understand how employers make decisions and use evidence around their investments in employee health. We have a newly published report representing a series of 12 interviews we conducted with senior corporate leaders across a variety of industries, and it reveals a difficult challenge for those charged with improving employee health in their respective companies. Often there is a heightened focus on healthcare cost reduction without due attention to work-related outcomes such as absence, performance deficits, and periods of work disability. The leaders interviewed understand that preventive and contextual factors may be critical for the long-term health and well-being improvement of workers, but sometimes meet with resistance in their organizations. Successful efforts at these employer organizations include breaking down silos to help human resource officers, safety managers, and health promotion staff better connect with each other and operational managers and hold themselves accountable for outcomes beyond healthcare cost reduction. This work also importantly involves efforts to bridge clinical perspectives and clinical research perspectives into the employment and the work context, understanding that work outcomes are a functional measure, a quality of life measure, a real world outcome for workers, for individuals who are working. And so we established expert panels and have developed a series of frameworks, collecting together feedback from clinicians and disability management practitioners, and conducting literature reviews on the existing evidence that associates chronic conditions with work-related outcomes. We connect the perspectives of clinicians and clinician researchers with employers and employees, and those working in the stay-at-work and return-to-work field. Reports related to this project will be released over the coming months, along with opportunities to engage in webinars and meetings. We surveyed our assembled clinical and disability management experts around the most prevalent chronic conditions if treated, we would expect work-related outcomes such as absence performance and work disability to improve. The panel chose the following 5 groups to study: diabetes, depression, cancer, pain, and multimorbidity. Now these last 2, pain and multimorbidity, represent features that cross conditions. Here we show you the draft diabetes framework that connects clinical indicators to work outcomes for diabetes. We will further develop the employer role to incorporate work context changes in addition to the treatment and behavioral changes already noted. We also welcome feedback as we see these frameworks as living documents that should change as the evidence does. We also will have a portion of our website where we allow individuals to easily search the evidence based on their interests, and that might be based on condition, as we are envisioning right now, those 5 areas I mentioned: cancer, depression, diabetes, multimorbidity, and pain, and by different audience types and groups, whether they are affiliated with the employer or a health plan or perhaps a medical director of a company. And we see this tool as being tailored to different audience types and welcome the suggestion of relevant materials for posting, and we'll have a way to make that easy for folks to submit over time. This last part of the presentation is all to bridge the excellent evidence that is being developed out there with practitioners, and to further incorporate the influence of practitioners' feedback on how we can strengthen the evidence base as well. I continue to believe that this is primarily a communication problem, not an evidence problem. We need to do better at translating findings and also in incorporating real-world perspectives into the research that we do. So with that, I will turn it back to the group and hope to be able to spend the last 20 minutes or so answering any questions that you may have.
Great. Thank you for the presentation. And to our audience, if there are any questions at this time, please enter them into the question and answer box on the GoToWebinar panel, and we'll ask them out loud. Some questions that came in. You mentioned in the study at the beginning of the presentation, there was done on small businesses in Colorado. What approximately were the business sizes?
Oh, that's a great question. I'm happy also to follow up with Angie after with more specific details for folks who had questions like this. They were mostly small employers ranging in size from, I'd say the average size is probably around 30 employees, but we had some larger school districts that went into the 600s in terms of employees. Again, this is Colorado, where there were a number of more rural areas as well, smaller communities. So it does represent one of the best studies ongoing to date that speaks specifically to small employers as well. And the group that is the lead, the University of Colorado Denver, is one of the newest total worker health units funded by the CDC, NIOSH, and they are with a specific focus on small employers.
Great. Another question that came in, did you measure employee turnover as part of the study? we're wondering if high employee turnover was a symptom of a low-performing workplace or the effect of low worker well-being.
Yeah, we did not measure turnover I don't believe in any of the studies I presented today, because you need full population data for that and really good longitudinal to be able to get beyond correlation. So great question. Most of the work that is out there on these kind of high level aggregate measures, there's been a lot lately on stock performance of a company and the health of the workers. It's correlational and it's not impactful, and we don't know which side is causing what. Mm-hmm. So we need really rich, good longitudinal information that includes these sorts of outcomes beyond just medical cost fluctuation. But that does look at, how long does an employee stay on the job, so that we can be able to get beyond the correlational work on some of these broad outcomes that matter. Now, there is good work, though, however, on work climate and turnover. So some of the measures I presented from the General Social Survey, which is a U.S. national survey on the safety climate and the work climate and different dimensions of work that affect employees, there's been a lot of research in that area on what we call good work, good jobs, jobs that have variety, flexibility, reasonable workloads, all of that. That is definitely directly related to turnover and not just correlational.
Mm-hmm. Mm-hmm. And another question, just confirming, is the website available now for resources, or is it still being populated?
It is being populated, so you can send me, if you're interested, you can send me an email if you have information you think might be of use. We will do an announcement when we have the more formal way of submitting material up, but I'm happy to consider in the interim any material folks might have. That'll help us also flesh out the query tool that we're going to use.
Mm-hmm. Yeah. Definitely keep that in mind. I think that's all of our questions for now. Dr. Jeanette, is there anything you'd like to add following your presentation?
No, I think just generally if there's interest from the audience in obtaining the underlying studies I mentioned or more information on how to submit material to the web page that we're going to have, the searchable web page, to feel free to follow up with me afterward. We also have active expert panels. So if you're might be interested in serving on a panel, if one of the 5 conditions that we mentioned is a particular interest area for you, we would welcome your expertise as well. So feel free to send me an email and I'll follow up.
Mm-hmm. We can definitely include those in the follow-up material to our audience too. Kimberly, thank you so much for your presentation. It was very informative.